Hello, I'm Chris Bonell. I'm a Professor of Sociology and Social Policy from the Institute of Education, and I'm going to talk about a systematic review we did, which was of health promoting schools interventions. A systematic review is a scientific way of collating all the evidence, answering a specific question, and highlighting the evidence which is of the highest quality, focusing on that evidence, synthesising it, summarising it in order to answer a question as well as we could. And the question we had concerned the effectiveness of health promoting schools interventions. Now, health promoting schools is a framework developed by the World Health Organization, which aimed to encourage schools to promote students' health, not only through providing health education through the school curriculum, but also by making the school in general a healthy setting, a healthy place to be, and also trying to improve health by reaching out to students and students' parents and the local community to encourage them to be part of an alliance to improve health too. For the sake of our review, we defined health promoting schools, as I say, being programs which not only address health through the school curriculum, but also address health through improving the school environment to make it a health promoting setting, and also by reaching out to family and community. Some of the interventions that we looked at in the review weren't explicitly entitled health promoting schools interventions. Often interventions from America and other parts of the world use different terminology, but as long as they satisfied those three criteria, they were included in our review. So our systematic review, and I'm going to use some jargon here which I'll explain. Our systematic review focused on cluster randomised control trials. I'll explain what that means in a minute. And it focused on studies which involved school children aged 4 to 18 years and focused on health promoting schools interventions. And we were interested in studies that measured the impacts of these interventions on a broad range of health outcomes, but also on academic outcomes like whether kids are attending school and how well they do academically, because we were interested in not only the health impacts but the educational impacts too. And the systematic review was done through the Cochrane collaboration, which is an international collaboration of people who are interested in synthesising evidence to answer policy relevant questions. So it might be good just to explain what a systematic review is. A systematic review is an important thing to do because any single research project isn't a good guide to policy and practice, because any single research study might have slight biases. It only reports on one sample of people at a specific point in time in a specific place. So it's really useful to gather together all the relevant studies that are able to answer a question. Now, traditional reviews, which are done by academics, are biased, either intentionally or unintentionally. The reason for that is when an academic's doing a traditional literature review, they have a tendency to include the research which agrees with their own personal biases, which is done by themselves or by their friends, and it might just be error that they fail to include really important studies. A systematic review tries to overcome these biases. It does this by trying to answer a specific, explicit research question which is fixed at the start and doesn't change. It comprehensively searches for all the studies on a particular topic, and then it has explicit inclusion criteria and quality assessment criteria to identify pertinent and well done studies. And then it has a clever statistical way of pooling the results, which I won't go into very much. I also mentioned the phrase cluster randomised control trial, which is what our review included. A cluster randomised control trial is an experimental design which is the best way to establish the effectiveness of a programme. What essentially happens is, imagine if you've got a study which is a cluster randomised control trial of schools. You recruit a bunch of schools who are interested in taking part in an intervention, say 40 schools. You then do baseline surveys of all their students to find out what the health status of their students is at the start. You then, after this baseline survey has been done, randomise the schools. Say 20 of them get the intervention, 20 of them don't get the intervention, and it's decided randomly, for example, even by the toss of a coin, but usually by slightly more sophisticated methods than that. And this randomisation means if you randomise enough schools, there should be no differences between the schools that get the intervention and the schools that don't get the intervention. So it removes any biases which might occur if schools were deciding whether to opt in or out. You then deliver the intervention in the schools, and then when the intervention's finished, or sometime after the intervention's finished, you do follow-up surveys to see what the health status of the students is after the intervention. You then compare the intervention and the control schools, the schools that didn't get the intervention, and you can then estimate the effects of the intervention, which should factor out all other causes of health that are going on at the same time, whether those are other health campaigns that are going on in the background, or the fact that the kids are growing up. It factors out all those other influences and really allows you to focus on the added value that the intervention provides. So that's what a cluster randomised controlled trial is. Okay, so we did this mammoth systematic review. We searched really comprehensively on a range of databases, websites, hard copies of journals in libraries, and essentially our searches found 78,099 articles that might be relevant. The vast majority of these wouldn't prove relevant, they were just picked up in our searches. So we had to go through those papers by hand, looking at the titles and abstracts to decide whether they were going to be interesting for us to look at in more detail. And of the 78,000, but after we'd eliminated duplicates, we were left with about 48,000. We then went through titles and abstracts, and about 2,200 looked like they might be relevant. And then we looked at the full text to try and decide whether they were relevant. And again, about 1,130 looked like they might be relevant. And after looking at the full text, we got it down to 67 studies, which definitively gave us data which we could use to answer our question. Now, to cut to the chase, what we found essentially was that health promoting schools interventions were effective for a range of different outcomes. A systematic review which was done about 12 years ago didn't find very many studies, and it couldn't really make very definitive conclusions about whether this new innovative approach to addressing students' health in schools holistically could work. The results looked promising, but they couldn't draw any definitive conclusions. And our results were much more positive. We found that the interventions were effective for reducing students' body mass index, in other words, reducing rates of obesity. They were effective in improving physical activity of kids, improving their fitness, improving their intake of fruit and vegetables, reducing their tobacco use, and reducing students' reports of being the victims of bullying. We couldn't draw any conclusions about mental health and sexual health because there just weren't enough studies out there. And somewhere in between there were studies of fat intake, alcohol, drugs, violence, and bullying others, and hand washing. Now, there wasn't enough evidence to say the interventions definitely work in these areas, but the trends were in the positive direction, so that looked pretty promising. I'll now go into a couple of examples in a little bit more detail just to show you what the results of a systematic review actually look like. So if you look on this slide here, it's a very complicated, busy slide, but I'll just take you through it. Essentially, it's got three bands of research findings. The first set of bands is focused on interventions to reduce tobacco, which focus exclusively on tobacco use. You'll see on the left-hand side the names of the authors of various studies. There's a whole bunch of different studies that are going down the page. They're grouped into four groups. The first group are looking at tobacco interventions which only focus on tobacco use. The second bunch of interventions are interventions which focus on multiple risk behaviours, such as tobacco plus drugs, etc. The third set of studies are focused on emotional well-being, and they're looking at the knock-on consequences of delivering those programmes on tobacco use. And the fourth set of interventions are alcohol interventions, but they're studies which also looked at the effects of those interventions on tobacco use. If you now turn your attention to the right-hand side of the slide, you'll see going down the page there's a line, and that line is called the line of unity. Any studies which are a dot on the right-hand side of that line means the intervention is harmful. Any studies where there's a dot on the left-hand side of that line, it means the study is beneficial. So there's a dot for each study, and then there's a dot, which is the dot indicating the effect of the interventions when they're pooled together. So essentially what you see, if you're looking at the big dots, which are diamond-shaped, you'll see that tobacco interventions are definitely effective. The line is definitely to the left-hand side of the line of unity. Multiple risk behaviour interventions are definitely effective. Emotional well-being interventions don't appear to be quite definitively effective. They're basically the left-hand side of the line, but the dot does touch the line, so there is some doubt statistically about whether there is a significant difference there. And then finally, alcohol interventions, there's only one of them, but it's effective in reducing tobacco use. Okay, so again, this next slide is busy. It's looking at being bullied as the outcome. The same thing applies. The detail on the left is about individual studies, which each constitute a row, and then on the right-hand side there's the line of unity. A dot on the right-hand side indicates a harmful intervention. A dot on the left-hand side indicates a beneficial intervention. There's 3 sets of intervention types. There's bullying interventions, then going down there's multiple risk behaviour interventions, and then going down there's emotional well-being interventions. The bullying interventions are definitively effective. The overall dot, which pulls the results of all the studies above it, the one with the circle around it, is on the left-hand side of the line of unity. With the multiple risk behaviour interventions, there's only one study and it crosses the line. So it's neither beneficial nor harmful, and we can't really conclude that the intervention is beneficial from that. Finally, the emotional well-being interventions. Again, this time the dot is on the left-hand side. There's only one study, but the line that goes through the dot, which indicates how confident we are about the estimate, crosses the line of unity. And what this means is it looks like the people in the intervention arm experience better outcomes, but we're really not sure if that's statistically significant. It might just be the play of chance. So we can't make a definitive conclusion that this intervention type is effective. So what this is telling us is that interventions focused specifically on bullying appear to work, but interventions which look at bullying and other risk behaviours such as alcohol, and interventions which focus on emotional well-being can't be concluded as being effective in reducing the experience of being bullied. So in terms of overall conclusions, what we conclude from this review, which took about 2 years to do, is that health promoting schools interventions now do appear to be a definitively effective approach for doing school-based health promotion and improving the health of kids in schools. But there is need for more research. There's need for more research, particularly in the UK, because only 3 of these studies that we found actually came from the UK, and they were all done in primary schools focused on healthy eating. We need many more studies done in the UK looking at other outcomes and addressing secondary schools as well as primary schools. And the other thing to bear in mind is that this kind of approach, even though it's effective, is quite challenging for schools to do in the current educational climate. The current educational climate is strongly focused on schools maximising the attainment of their students, and the policy environment that schools are working within really doesn't encourage schools to do very much more than that. It doesn't provide much funding or much guidance for schools to take part in health initiatives, and in some way actually discourages them from doing that. So this kind of intervention, although effective, may be being undermined by current educational policy.